بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. The title of today's lecture is Cleft Lip and Palate, Dental Implants Gave Them the Smile, presented by Dr. Walid Sadig. Cleft lip and palate is considered a major public health problem. Orofacial clefting is the second most common congenital deformity after club foot. Prevalence of cleft lip and palate in Saudi Arabia is 1 in every 800 births in Riyadh, Jeddah and Medina. 40% of the cases are cleft lip, 36% of the cases are cleft lip and palate, and 24% of the cases are isolated cleft palate. Unfortunately, many in the public, they refer to this anomaly as hair lip, which will cause social stigma to the patient. They feel subhuman and low self-esteem. Also, it will affect their self-concept. The aim of habilitation is to enhance the quality of life of the affected children, to ensure their full social inclusion with their peers, and the ultimate goal is to let them smile and act with confidence. By the way, this is Joaquin Phoenix, the famous actor. He is one of the cleft lip heroes. Management of cleft lip and palate is a multidisciplinary team approach to assure integrated case management, assure quality of patient care, and longitudinal follow-up. The medical team include the plastic surgeon, the pediatrician, the ENT surgeon, and the psychologist and the genetist. The interdisciplinary team approach of the dental team include mainly the orthodontist, the surgeon, and the prosthodontist. The role of maxillofacial surgeon with cleft patient is to evaluate facial form, function, and jaw position, participate with the ENT surgeon in palatoplasty, augment bone defects, perform orthodontic surgery, and finally place dental implants. The role of the orthodontist is to perform diagnostic documentation, maxillary expansion. He monitors the teeth eruption, and he decides the timing of bone grafting, and he do teeth alignment with bite correction, i.e. comprehensive orthodontic treatment. The role of the maxillofacial prosthodontist is to replace missing teeth, restore function, introduce feeding appliances, fabricate hard and soft palate obturators, also fabricate fixed and removable prostheses, and finally, at the age of 17, the prosthodontist propose implant placement and restore it later on. Although many specialties they work with the cleft lip and palate cases, however, there is still suboptimal care because of diagnostic errors, poorly timed treatment, and poorly performed procedures. Cleft patients' reconstructive journey is very long and painful. In the beginning, they have soft tissue surgeries, which is lip closure, in the first 2 to 6 weeks. At 10th and 12th weeks, they have definitive lip repair. In the first year and year and a half, they have palatal repair. At 7 to 9 years, they have the alveolar bone grafting. During the adolescence, they have comprehensive orthodontics. And late adolescence, they have orthodontic surgery. At the age of 15 to 17, they have regrafting for implant placement. Then in adulthood, they have implant surgery. and at the end stage they have definitive prosthesis, which is a lifelong commitment by the patient and the prosthodontist. Definitive lip and nasal repair was first introduced by the famous German surgeon Millard. He is the one who proposed the rule of 10, where surgery is performed when the child reaches the weight of 10 pounds at the 10th week and the hemoglobin level is 10 gram per deciliter. Timing of bone grafting shows some variation among cleft habilitation centers. Primary osteoblasty used to be performed during the deciduous dentition. However, this technique was abandoned by many because of the drawbacks in retarding jaw growth. During the mixed dentition, early secondary osteoblasty is done when 2/3 of the lateral incisor root has been developed. Secondary osteoblasty, which is the most common, is done when 2/3 of the canine root has been developed, and late secondary osteoblasty is done after canine eruption. Tertiary osteoblasty is done when the patient is in his adulthood. Secondary osteoblasty provide bone into which the canine can erupt. As you can see, this is a bone graft just like pyramid, and it goes here, and this is the floor of the nose, and this is the lateral wall of the bone graft, and this is the anterior wall of the bone graft. As you can see, this is the canine before eruption. Autogenous bone grafting is the gold standard, and the healing period is 6 months. Lately, they are using bone morphogenic proteins to replace the autogenous bone graft. However, the healing period is longer. It is from 8 to 10 months. This slide will show how the bone grafting is performed. The soft tissue is reflected and the floor of the nose is closed with the soft tissue. The bone graft is placed there, and this is after suturing. The donor site of the block autograft in 80% of the cases from the iliac crest. As you can see, this is a surgery, the donor site from the ilium, and this is a iliac crest bone, and this is how it is placed in the side, just like puzzle, to close the defect. And this is a soft tissue closing the floor of the nose. If the bone grafting is performed very well, usually the orthodontist, they like to move the canine mesially, as you can see here, to close the space. However, if the canine is too big, this will affect the aesthetic result. That's why prosthodontists, they like to have it open and place dental implants and have regular lateral in that area. In the majority of cases, the patient will end up with orthognathic surgery when he is in the adulthood to correct the open bite and the retruded maxilla, and later they will have tertiary grafting, so the space can accommodate dental implants. The alveolar bone grafting is a difficult procedure because of the limited soft tissue available, and sometimes there will be dehiscence of bone and infection in the bone graft. This slide will show the need for tertiary grafting. As you can see, the canine is still not totally developed and the soft tissue available is very limited. That's why pulling and mobilization of the flap will lead to dehiscence. This is the main reason that bone grafting is not very successful in all the cases because of the complexity of the procedure. Tertiary bone grafting usually is done to correct the defect in the missing lateral, and the best bone graft comes from the retromolar area. According to Khalil et al., 75% of the bone grafts are acceptable, 10% cannot be acceptable, and there is failure in 5% of the cases, and the borderline in 10% of the cases. There is two scales to evaluate bone graft using radiographs. The first one is the Bergland scale, which in type 1 there is 0 to 25% resorption. In type 2 there is 25 to 50% resorption or atrophy in the bone. And in type 3 there is 50 to 75% atrophy. And in type 4 there is 75 to 100% atrophy. There is another scale called Chelsea scale. As you can see, this is type A, type B, type C, and type D, type E, and F. The shadow area is the remaining bone. The implant placement can be placed in type 1 and type 2, also in type A and type C, and sometimes in type D. Removable prosthesis in cleft patients has decreased in the last 30 years because of the improved surgical techniques. To manage the defects of the cleft lip and palate cases, we perform several appliances such as feeding appliances, positioning appliances, nasal conformer, articulation prosthesis, palatal lift appliances, and palatal obturators and palatopharyngeal obturators. In this lecture, we will concentrate only on the feeding appliances because of the rest of these appliances are rarely done at present. To replace the missing teeth, we perform removable partial dentures, complete dentures, overlay prosthesis, and fixed restorations, implant retained restorations, and implant supported prosthesis. In this lecture, we will concentrate only on the fixed restorations and implant supported prosthesis. If soft tissue correction surgery is not performed for any reason, prosthodontist can perform feeding appliances so the patient or the child can have easier feeding, better thriving. Also, this will eliminate the risk of feeding tube, and the patient or the child will have better surgical outcome. On the next few slides, feeding appliance will be presented step by step. The custom tray fabrication starts with imagining the size of the defect by letting the child cry. Then we do the wax up. After that, we duplicate it in cast, and later on we will perform the custom tray. Impression registration is done when the child in the upright position. We can use a putty, silicone material, or alginate, but we have to make sure that the alginate is not soupy. Feeding appliance is simple heat cure acrylic templates. It is delivered to the patient by using reline, and also dental floss is tightened in the front, so in case of the feeding appliance falls down, the mother, she can pull it away. Feeding appliances is considered great psychological support for the parents. Why? Because once we deliver the appliance to the patient or to the child mouth, the child immediately will start to suck the finger, and this will give emotional moments to the parents. When a cleft patient goes through all the required sequence surgeries, all what he needs in adulthood is a fixed restoration, which is preferable on all cases because of the stability, longevity, and comfort. However, there are some challenges that face the prosthodontist before rendering the appropriate treatment, such as impacted teeth, high lip line, and canines in place of the laterals. Resin bonded bridges are one of the alternative solutions that can be proposed to the patient. However, this option is considered a short-term solution in regard of longevity. And because of the frequent debonding, many times we have to jump the bonded bridges to a conventional fixed partial dentures. Another option is to use bondable fiber ribbon bridge. Rib bond is one of the commercially available ribbons that comes with different size. Conventional bridge is another alternative when bone augmentation is not sufficient enough to accommodate dental implants. This slide shows missing 3 anterior teeth with horizontal bone defect plus reverse bite. For such cases, a conventional bridge was fabricated with convex ovate pontic to prevent irritation to the underlying soft tissues. In cleft cases, whenever possible, we try to maintain tooth position in clefting area. In this case, a conventional overlay telescopic bridge was introduced to maintain the amputated central in place and hence preserve the bone. This is the final bridge of the previous case with some pink porcelain to replace the soft tissue missing in that area. This is another case with 3 missing anterior teeth but with the severe horizontal and vertical ridge defect. With severe horizontal and vertical ridge defects, we designed the bridge with highly glazed ridge lap pontic with some pink porcelain. There is no white aesthetic without red aesthetic. Pink porcelain is very important for cleft cases. It will give a lifelike transition from the crown margin to the gingiva. To achieve perfect gum shade matching, initial gum shade powder stain kit and IQ luster paste from GC will give superb results. Many of cleft patients represent with hypoplasia and triangular teeth in shape, which necessitate restoration of all the anterior teeth. The slide shows the final results of the previous case, in which a 3-unit bridge was fabricated in the right side and 2 crowns was fabricated on the central and the lateral on the left side. In cases with slight mobility of the abutment teeth adjacent to the cleft area, double abutment is necessary to render better stability of the bridge. For that purpose, the bridge has to be segmented to overcome the different paths of insertion. Now we move to dental implantology at cleft site. Dental implants is considered as one of the fairest options at cleft area. The first implant was placed in 1991. This was done by Verdi et al. And published in the Cleft Palate Craniofacial Journal. Implants at the cleft site should be considered the standard of care whenever possible, and the success rate ranges between 90% to 98%. Implant prognosis is compromised because of several reasons, such as proximity to the nasal floor, limited bone height, limited bone width, inappropriate bone length in the dental arch, poor bone density, and bone level to the adjacent teeth is compromised. On the following slides, several cases using dental implants at cleft sites will be presented. In this particular case, the lateral incisor area was regrafted using bone graft from the retromolar area. During the healing period, bondable fiber bridge was used as transitional tooth replacement. After 8 months of bone augmentation procedure, Straumann bone level implant was inserted. During the healing period, resin bonded bridge was given to the patient as transitional. After 3 months of healing period, cementable abutment was tightened in place and the final crown luted with zinc phosphate cement. This is another case of unilateral cleft. Cemented restoration was planned. Because of the fragility of the soft tissue around the abutments, it is recommended in cleft cases to use diode laser for tissue retraction. In this slide, you can see the final restoration on the lateral incisor in place. This is another case of a unilateral clefting at the left side with bilateral palatal cleft. At present, cone beam images is mandatory for all cases. For the same case, two Astra 3 mm in diameter implants were placed on the missing lateral area. This slide shows the final crown in place. Pink porcelain was not used to avoid overbulking of the cervical area of tooth number 22. As you can notice, the patient had low lip line and she was very happy with the aesthetic results. This is another case of a unilateral cleft with missing central. Straumann bone level implant was placed and restored with PFM crown. An effort was done to close the space between number 21 and 22 by crowning number 22. Unfortunately, the papilla did not regenerate between the central and the lateral. Therefore, a palatally pedicle soft tissue graft will be attempted in the near future. In this cone beam image, you can see the fixture surrounded by a small amount of bone. The implant did not osseointegrate after 1 year of healing period. The fixture was replaced by a new one and the patient was told to wait and see. In this case of a unilateral cleft, bovine bone graft failed twice. However, the autogenous bone graft from the crest of the ilium succeeded very well, and Camlog implant was used to restore the missing lateral. Although bone grafting was successful, this resulted in soft tissue pulling and smaller vestibule to cover the oversized graft and implant. Now we will move to implant placement at bilateral cleft cases. This case was done 10 years ago. Over the first year, you can see the papilla was regenerated between the centrals and the laterals. After 10 years of follow-up, the patient presented with some signs of pre-implantitis with some exudate. The patient was treated with a specific protocol to eliminate the disease. The interceptive management of this case was done by using diode laser to clean and decontaminate the implant surface, and two types of antibiotic, gram-positive and negative, was given and prescribed to the patient. This is another case of using implants at bilateral cleft. As you can see, there is a deciduous tooth on the left lateral was removed and implant was placed there. Two cemented on abutments were placed and restored with PFM. In the left side there was little space between the central and the lateral, and the patient was unhappy with the static results. The ideal treatment for that case should be removal of the deciduous teeth and moving and closing the gap orthodontically before placing the implant. This is the last case where we have done two implants in the bilateral cleft area, one in the right side and one in the left side. In the left side the space was big. We have used a cantilever on the cemented on restoration, whereas in the right side it was a screw retained restoration. This is the final results of putting a screw retained crown on the lateral in the right side and cantilever central to the lateral on the left side, and the patient was very happy with the aesthetic results. In summary, the treatment outcome: 9 cases was restored with implants, 4 of them are males and 5 are females. 6 cases are unilateral and 3 cases bilateral. The total number of implants are 12. Only 1 implant failed and 1 implant did not osseointegrate. In 1 case we had pre-implantitis, and in 1 case the patient was unhappy with the aesthetic results. Since most of the implants placed in the area of missing laterals in cleft patients, we need to review the diameter of implants. NDI, or narrow diameter implants, can be categorized into Category 1, which is less than 3 mm in diameter, Category 2 between 3 and 3.25 mm in diameter, and Category 3 between 3.3 and 3.5 mm in diameter. Many implants comes as 1 piece or 2 pieces. In my opinion, we should avoid using many implants in cleft area as much as possible. Also, it is better to use implants or fixtures with internal conical hex connection. Lately, Straumann came up with BLX implants with aggressive thread design to provide greater initial stability. The 3.5 mm diameter is ideal for grafted bone in cleft cases. This slide summarizes the optimum fixtures for grafted bone in cleft area. The implant body should have a diameter between 3.25 to 3.5 mm. There should be micro thread in the neck, no polished collar, hex conical connection, minimum 10 mm in length, SLA surface, aggressive thread body, tapered self-threading apex so the fixture can be countersinked down into the bone. Optimum abutments for implants at cleft side. Screw retention should be our first priority. This slide shows typical case of post-orthodontic treatment of non-cleft patient. The area of the missing lateral is grafted, implant fixture placed in optimum trajectory to receive screw retained restoration. Unfortunately, with cleft cases, this is not always possible. Because of the non-axial placement of implants in cleft patients, UCLA abutment is difficult to use. Therefore, the angulated multi-base abutment will be the solution to provide screw-retained restoration. Another additional feature that should be put into consideration when selecting an implant for cleft patients is to utilize the concept of platform switching. Also, is to utilize implant that can be placed subcrystally. If cemented-on restoration is used, it is recommended to use anatomical abutment with variable cuff height to minimize the excess cement. For cemented-on restorations, hex conical connection will minimize the stresses to the crystal bone. Furthermore, the bigger cuff diameter will provide better emergence profile. Also, the smaller, longer screw shaft will minimize screw loosening and screw fracture. To achieve optimal aesthetic results, the state of the art now is to use zirconia abutment with metal base, and this is called hybrid custom meld. The motto of Cleft Lip and Palate Awareness Day indicate that each smile tells a story. And this is absolutely true, as we notice that all cleft patients become very emotional when you ask them about their past surgeries. And my conclusive remark that prosthodontist makes the happy endings. بمعنى آخر أخصائي التعويضات يصنع النهايات السعيدة. Thank you for listening.